If the patient has a bow legs going inwards or going outwards, these patients will have high risk of developing osteoarthritis. So inward bowing is called as genu varum, and outward bowing, that is called as knock knees, or it is called as a genu valgum. So these are a precursors for again a rapid progression or fast progression of osteoarthritis, and these can be addressed with two procedures: high tibial osteotomy for a varus knee and distal femoral osteotomy for a valgus knee. And these procedures can make the alignment correct and improve the loading. So again, as I told you, you can do a high tibial osteotomy surgeries to transfer the weight bearing loads. So you have, if your weight bearing axis is not perfect, you can make them perfect by doing a high tibial osteotomy. So when a high tibial osteotomy can be done, it can be done in a young patient less than 60 years of age. A unicompartment, only one side of compartment is involved, medial or lateral. You have a varus or valgus deformity. If you have a ligament problems, you can do osteo. There is no contraindication. You should have a good range of motion. The knee should be bending completely and extended completely. The patient should be able to use crutches after the procedure. When osteo should not be done is when you have a pan-compartmental arthritis, medial, lateral, patellar, everything is involved. Then you should not do osteo. The range of motion is there is an FFD, or there is a large bone loss, and specifically in rheumatoid arthritis, osteo is a contraindication. So if there is a rheumatoid patient, you should not do an osteo. Again, your weight bearing axis should be passing from the Fujisawa point. So this is around the lateral tibial spine. So if you have a varus or a valgus knee, and if it is passing medially or laterally, then there will be a faster progression of osteoarthritis. And then you can correct it with doing osteotomies. So these are the osteotomy procedures that we do. These are actually intra pictures. And this is how we do it. So this is a nuclear plate. This is a French technology. And in this, you have an anatomical plate. You have a plate which is different from the right side, plate which is different from the left side. You do an open wedge osteotomy, you fix it well. You may or may not need a bone graft, and you can correct the alignment. Many times we combine the root surgeries or the root fix surgeries, meniscus repair surgeries with this surgery. So it performs a total knee preservation, correcting the meniscal tears and correcting the knee alignment together. And by and large, the take-home message from my talks are basically the early diagnosis. It is very, very crucial. Get in habit of doing an early MRIs of those patients who are presenting to you with mechanical symptoms like locking, popping, sudden increase in pain, effusion, instability. So try to do early MRIs in those patients. A comprehensive management is important. Arthroscopy has evolved a lot from the meniscectomies which were done in the past. By today, now we are not recommending meniscectomies, and we are able to repair meniscus in most of the cases, and that will restore the biomechanics of the knee. So root tear treatment, as I emphasize, it's a very common thing, very common missed diagnosis. So if you have an MRI diagnosis of a complete root tear, better to do a root repair with like a root fix device. Meniscus injury, again I emphasize, you need to repair them, not to do a meniscectomy, because if you do a meniscectomy, it will not prolong the life of the knee. It will actually, the progression will be the same. If you do a meniscus repair, you can actually delay the progression and delay the osteoarthritis per se. Ligament injuries like ACL and PCL can be treated with reconstruction surgeries. And if you have an alignment problem with an early OA, osteo can do wonders, and this can be combined with root tears, root repairs, ligament injuries like a ligament repair, ligament reconstruction surgeries like that. Thanks a lot.
Thank you, Dr. Babu. We'll take questions at the end of session. For the next talk, I invite Dr. Vivek Shetty.